Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Our topic today is the child who sleepwalks. Studies suggest that about 5% of children sleepwalk. Most often, sleepwalking is managed by pediatricians or family practitioners, but children with very frequent or injurious sleepwalking may be referred to sleep specialists, especially if the behaviors persist during later childhood or the teen ages. To discuss this problem, my guest today is Dr. Robin Lloyd, Associate Professor of Pediatrics and a board-certified sleep specialist at Mayo Clinic in Rochester, Minnesota. Robin, thank you for coming today. Why don't we start by having you remind our listeners of the stage of sleep in which sleepwalking occurs and whether this is an isolated problem or how it is related to other similar disorders such as sleep terrors and confusional arousals.
Excellent. Thank you, Mike. It's an honor and a pleasure to be here today, and I'm happy to discuss this important topic. I first want to take a step back, and you'd mentioned that it's estimated 5% of kids are affected with sleepwalking. I think it's important to note that most events are not observed, and so this is a gross estimate. Some studies have suggested that it may be as high as 15% of children are affected with sleepwalking, certainly because it's an estimate and the children are not observed. It's not clear exactly how many kids are affected. It is a common problem that does come out of stage N3 or slow wave sleep. Because it's considered a partial arousal parasomnia, it is indeed related to confusional arousals, sleep terrors, and other such non-REM partial arousal parasomnias. In one study that was published in JAMA Pediatrics in 2015, it demonstrated that about a third of children who had sleep terrors during early childhood went on to be sleepwalkers in later childhood.
So clearly a close relationship to the two conditions. So why do some children, whether it's 5% or as high as 15%, sleepwalk, and the majority, probably the majority, do not? What predisposes to this? And then perhaps we can talk after that about a person who is predisposed to sleepwalking. Why do they have sleepwalking on a certain night and not another night? What precipitates it? Do we know that?
So, yes, there are multiple factors that predispose a child to sleepwalk. First of all, there's a genetic predisposition. So, multiple studies have demonstrated that if parents are or were afflicted with parasomnias in childhood, their children are more apt to have uh, parasomnias during childhood. Similarly, twin studies, there was a nice study that demonstrated that monozygotic twins had 6 times higher rate of sleepwalking as compared to dizygotic twins. So genetic predisposition is a big factor. Secondly, sleep deprivation. We know that the days are getting longer and the nights are getting shorter in our society. And we know that sleep deprivation is indeed a major risk factor for parasomnias, especially since they typically come out of N3. And we know that sleep deprivation leads to rebound increases in stage N3 subsequent nights. We know that any condition that leads to increased arousal from sleep, such as a primary sleep disorder, such as sleep apnea, where a child may have sleep fragmentation related to this can be a predisposing factor for parasomnias. Illness, we know that when children have febrile illnesses, they tend to have more episodes. And also age. So kids who are older teenagers, they tend to outgrow the parasomnias, whereas younger children, much more prevalent. In one study that was out of the Canadian system where they followed kids longitudinally, ages 2 to 6, around 90% of parents reported at least one parasomnia in this age group. So very, very common with younger ages.
So it's one way of looking at it is that anything in someone predisposed genetically to it in the right age group, anything that deepens slow wave sleep, such as sleep deprivation, or increases the potential for arousal out of slow wave sleep, such as environmental stimuli or febrile illnesses or something like that, could precipitate it on the specific night. Would that be a reasonable formulation?
Yes, that would be correct.
Okay, well, that's interesting because, of course, it does give rise to interventions we can do to try and reduce it. So, um, we're sleep specialists. We like doing sleep studies. We certainly don't do them on every patient. It's so common, sleepwalking. When is a sleep study needed to make the diagnosis? I mean, as we said, the vast majority of children who sleepwalk don't ever come to a sleep specialist. If you're going to do a sleep study, is there some specialized way you do it? Do you add extra channels and electrodes? Let's start with that, and then we can talk about perhaps when you're reviewing a sleep study with sleepwalking or other arousal parasomnias in mind, what do you look for that's different from the way you look at a more common sleep study, say for sleep disordered breathing?
Yes. So a lot there. Indeed, most kids with parasomnias do not need a sleep study. And indeed, most kids aren't going to end up at the sleep specialist and that they will be managed by the primary care physician, especially if there's a good story. So many people have videos. Um, Oftentimes there's a family history. And so people say, oh my gosh, here we go, another family member who sleepwalks. So indeed, these folks are not going to end up at our door. The kids who need sleep studies are those where you're concerned about a primary sleep disorder, such as maybe obstructive sleep apnea leading to partial arousal phenomenon or periodic limb movements, or if there's concern about a seizure. So in an older child, multiple events, stereotyped events, enuresis, tongue biting. So concerns that are these episodes seizures or are they true simple non-REM parasomnias? That would be another reason to do a sleep study if one's concerned about REM sleep behavior disorder. So typically what I would do is if there's concern about seizure or RBD, then I would add a 16 to 18 lead montage, EEG montage to try and assess for seizures. And then I would add arm EMG or arm leads to assess for increased tone and REM. When I'm looking at these studies, the main things that I look for, so some parents will say, they don't happen every night. What if it's on a night when he doesn't or she doesn't have one of these episodes? And I always try to offer reassurance because what we're looking for in the sleep study is number one, what may be predisposing to partial arousal. So again, looking for primary sleep disorders, or is there something that we can capture that's leading to partial arousal? So that's the first thing. The second thing is if indeed we capture an episode, we try to see if there are EEG changes that are of concern. Um, but most kids with these episodes will not require a PSG, but if there is concern about seizure, RBD, or primary sleep disorder, I will go ahead and do a full PSG with 16 to 18 lead EEG montage and arm leads.
Very helpful. So, when I study some of these patients who are adults, and of course, that's the small minority of sleepwalkers that persist into adulthood, or sometimes occasionally start sleepwalking in adolescence or adulthood, we more commonly do sleep studies because it's less common in that age group. And
Mhm.
we want to be sure, again, we're not missing seizures, exactly as you say, or REM sleep behavior disorder. Something
Mhm.
I've developed over the years has been to look at the hypnogram hypnogram and identify all the transitions from slow wave sleep to wakefulness. And
Yes.
every one of them, I bring up the video and look, because I've seen in many adults anyway, confusional arousals occur with those where instead of just the usual thing, the patient just turns over and
Right.
moves a little, which means very little. But in these cases, the patient half sits up and looks startled and looks around in a confused way. And I
Yes.
found that, and that's often missed by the technologist
Yeah.
supervising the study. And I found that very helpful in confirming the diagnosis when there's no overt sleepwalking, as you say, when there isn't, certainly in adults. Is
Yes.
that helpful in children, that type of
Oh,
approach?
absolutely. I do the same thing where I look at the hypnogram. I look at all stage and 3 abrupt arousals and see what's going on.
Good. Um, Are there behavioral techniques available to manage sleepwalking? I'm sure, again, I don't manage children myself, but I'm sure most parents don't want medications for their children unless they're essential. How are there behavioral techniques? How effective are they?
Absolutely. So I think first and foremost, trying to ensure that the child is having sufficient sleep opportunity. And again, that can be difficult. In today's society, it's amazing how many kids' activities, even young children, have activities scheduled later into the evening, and this can lead to sleep deprivation. Um, we know that when kids are having more disrupted schedules, so it's amazing how many people I have been to Disney, and the next week they're calling and saying, "Oh my gosh, my child was found in the lobby of the hotel by the manager, and this is terrible." And so disrupted sleep schedules, insufficient sleep are big targets that we can focus on to try and have behavioral interventions to help with sleep. Similarly, technologies. So we know that the technology phenomenon and invasion into our child's lives, it's just so prevalent and it has such a negative impact on sleep. There was one study published back in 2015 in Sleep Medicine where it showed that television watchers and kids who were television watchers at bedtime, they had a 4 time increase in reported sleepwalking. So removing those technologies from the bedroom, from around the bedtime routine, I think is so important. Um, there's a technique called preemptive awakening or abortive awakenings that some people will try. This is helpful in those children where they're just like clockwork. And I've had some of these kids where the parents say, "You know what, I put them down at 8 and between 9 and 9:30 every single night we have one of these episodes." And so trying to awaken the child maybe 15 to 20 minutes before these typical episodes, again, it's helpful if they're on a fairly regular schedule. Sometimes this may trigger an event, but sometimes this is just enough to change a sleep state so that maybe it aborts an event, and then eventually the parents can wean off of the abortive awakenings. There isn't good literature, so not a lot of good clinical studies, but a few reported um, case reports essentially. So one group of 3 reported successes using this technique. So it can be helpful. Again, it's worth a try. There aren't a whole lot of downsides other than the fact that one may trigger an event, but it's worth a try. Those would be the main thing. I guess I should add that it's important to avoid external stimuli. So I mean, sometimes I had one young man who came up from Chicago, and turns out it was the L train was going past his apartment, rattling the building. And anyway, we were able to put that together. But sometimes something as simple as the family dog wandering in and settling in for the night, but disrupting the child's sleep. So I think it's important to assess for external stimuli that may lead to partial arousal as well.
Now, in adults, we've had some experience with hypnosis. The late Peter Howry and I and some others wrote this up some years ago, our
Right.
experience in adults. It wasn't fantastically successful, and we just had a uncontrolled case series, but some patients seem to benefit, and we do use this in patients, in adults with sleepwalking who don't want to be on medication, with some success. Is there a role for hypnosis at all in children or adolescents with sleepwalking and other
Um,
parasomnias?
So great question, and I personally have not utilized this resource. Um, I think it's again a non-pharmacologic approach that may be worth a trial. Um, I just There isn't a lot of literature to support it, but again, if people are interested in a non-pharmacologic approach, that may be something that, and the child is old enough and cooperative enough to be able to participate, that may be another adjunct to therapy.
Great. So let's get to medications. When should medications be used for children who sleepwalk, and which drugs do you personally prescribe?
Yeah. So again, I think really addressing the non-pharmacologic approaches would be the mainstay of therapy, but in the very few people who I do prescribe medications to, they would be the kids where the episodes are extremely disruptive to the families, where they're occurring quite frequently and potentially injurious. And I've had some really scary things that I think families are they're scary for me to have learned about, or families will bring um, videos. They're scary to observe. So so basically, those would be the three things where they're very frequent and disruptive, um, and potentially injurious. Those would be the kids that we would want to go ahead and consider pharmacotherapy. When we're looking at treatments, I typically use clonazepam. Most kids have not seen a lot of medications, and so I would start with a low dose and then titrate up if need be. Because kids are going to outgrow these episodes, I usually give it for maybe 6 months at a time and then try and wean off and see if they've outgrown these episodes. Since it seems, silly to have someone on a medication long term and when it's unnecessary if they've outgrown the episodes. Um, but again, really looking at the non-pharmacologic approaches first. Some people have utilized melatonin, the tricyclics, the SSRIs, especially if there may be some sort of um, mood or anxiety issue, because sometimes, especially as kids progress into teenagehood, there's a little bit higher association with anxiety and sleep disruption, sleep fragmentation, or nonspecific arousals related to that. So in that situation, maybe an SSRI may be helpful.
Obviously, the doses depend on age, I would imagine. Is there any sort of general range you could advise on clonazepam in a rare situation
Yeah.
to use
So
it?
I start with the lowest possible dose, so usually a 0.125 milligram, and I don't believe I've ever exceeded zero point 0.5 milligrams.
Oh.
So yeah, most commonly the kids are in that kind of um, 0.25 kind of range.
Yes, interesting,
Yeah.
because that's a different range from what we use in adults with injurious sleepwalking. In an older person, say with REM sleep behavior disorder, we might start at 0.25, but most of my sleepwalking adults need between zero point 0.5 and 2 milligrams to get reasonable control. So
Mhm.
it's a different dose range. I think it's important for our listeners to realize that.
Yeah. Again, kids just typically have not seen that many medications, and I think it's important to start low and adjust if need be.
Well, what final messages would you like to leave with our listeners?
I think the biggest message I'd like to leave is safety, safety, safety. So I just don't think we can stress how important it is to make sure there's a safe sleep environment. It's amazing how many kids I've assessed with parasomnias who are sleeping on a top bunk. Um, I had one young boy who had a knife collection in his room. So those are obvious, but even sharp corners, unlocked windows. I think it's so important that we stress the safety issues around these parasomnias. So I strongly encourage people to have locked windows, locked doors, some sort of alarm on the child's bedroom door. And it doesn't have to be expensive or fancy. I've had people go out and buy a cowbell and put it around the doorknob so that hopefully if the child opens the door, it may alert them a little bit more, or perhaps alert their parents so that they can be aware that this is going on. So some sort of um, alert or alarm. But of course, living in the upper Midwest during the middle of winter, I can't stress how important it is to double lock the outside doors. We've had kids who have wandered outside in the winter, and that's pretty frightening.
Well, thank you so much for sharing your expertise. I'm sure this has been very helpful to our listeners.
Awesome. Well, thank you for inviting me today. Thank you.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.